As Graham said, I'm a general physician and see patients with COPD in that context. And one of my passions is the early diagnosis and management of COPD, which was wearing my clinical and research hat. Today, I'm hoping to present to you a more simplified way of treating COPD. I've given this type of talk before, and I know how complicated it's been made by the super specialists in Europe and America who convene with first-class travel in exotic places in the world and provide us with recommendations that have not always been greeted with great enthusiasm. And I'm seeing a trend now back towards something that's much simpler, which I hope to share with you today, and hopefully it will give you some guidance. In particular, what's new about this is a focus which has been absent for several decades, really, of this group of patients who transition from asthma to COPD. And the respiratory gurus are really starting to take a look at this group of patients. And so this is something I'll touch on today. The other thing today is also the complicated issue of where, excuse me, inhaled corticosteroids fit in the management of COPD. In asthma, it's much clearer, but in COPD, it's been a point of contention, and a concern about the overuse of inhaled corticosteroids has emerged. But I hope to show you some interesting data around that to reassure you that inhaled corticosteroids still have a significant role to play in managing patients with COPD. So, as Graham said, I have a slightly varied background in academic medicine, partly related to genetics, but more recently in epidemiology and also in, as I say, wearing my clinical hat, treating patients that come in with exacerbations. Just to say that I've been paid for an honorarium for this presentation. I have received honoraria before from GSK as part of being on an advisory board, but I'm not an employee and I have no shares. Yet, maybe, never. Anyway, the overview really of this presentation is to touch very briefly on COPD and the recently available funded treatments, to just remind you about the diagnosis and symptom assessment, looking at this idea of treatable trays, and that's actually going to be much simpler than it sounds, and in particular, how do we use the LAMA-LABA combination medications that are now available that we didn't have 3 or 4 years ago as part of the algorithm of treatment in COPD. And again, just repositioning inhaled corticosteroids in that setting, excuse me, and not to forget the non-pharmacological treatments and some of the changes in really the recommendations in this regard. So as a reminder, and in a way this has been touched on already by Graham, but COPD is a significant cause of morbidity and mortality. Studies predicting it to be the 3rd leading cause of death before long. We have 6,000 newly diagnosed each year in New Zealand and about 200,000 total. Most of COPD is linked to smoking, although there are recognized other air pollutant type exposures from the workplace or other areas which may contribute. And there is, as I say, this group of patients that transition from asthma to COPD primarily in the context of a smoking background. Now, COPD affects the Māori and Pacifica group disproportionately. I can say, wearing my research hat, that Māori do poorly with lung cancer in the context of COPD, and we've recently published work in that area. But for me, COPD remains a disease that is underdiagnosed and undertreated, and I hope to just clarify that during the course of this presentation. So here are the leading causes of death where cancer has been broken down by individual cancers, and so that places COPD there on the 3rd highest. 3 million deaths in 2016, those are global figures. And then just to say, and something that's a bit underappreciated, I think, is that at least a half of lung cancers have COPD. And as I say, we think that's not just because of the smoking. And also a significant number of respiratory deaths from infection are also in patients with COPD. So I suspect we underappreciate the contribution COPD has to patient death and mortality. Now, what are the funded long-acting inhalers? This is a diagram taken from BPAC, who've done a really nice job at providing this color chart really that shows you the new medicines. So a few years ago when I gave this presentation, we'd talk about llamas and it would be about tiotropium. And now we have glycopyrronium, we have umeclidinium. And more recently, in the last 2 years or so, we have the LAMA-LABA combinations. And so there's been a considerable interest in where these fit into COPD management. And we've had for some time the option of ICS-LABA combinations, and these have been important in asthma and in COPD management. And we have more choices now in terms of those combination therapies. You won't be surprised to know that in the future there will be triple therapy, and these will be in single inhalers. And so the more recent inhalers amongst this group are single puff once a day with long-acting duration. And the option here is now for some patients that may even triple therapy may be relevant for some. And I'll touch on that and just to present some data along those lines. So how do I diagnose and assess symptoms in my COPD patients? We know that COPD often has an insidious onset, and it's progressive breathlessness with exertion. But I'd also point out that we have a lot of patients that come in with chest infection that have cough and sputum, and on clinical exam may have wheeze, they may describe chest tightness, that may be their first presentation of a COPD exacerbation. And so we just alert you to this group of patients. We also have those that are chronic sputum producers, the sort of more chronic bronchitic type of patient with COPD. But really, it's the key symptoms of breathlessness, cough that could be chronic or it may be acute as part of an exacerbation, recurrent lower respiratory tract infections, and the risk factors, things such as tobacco smoke, other smoke exposures, and occupational exposures. Okay, so there's nothing really new here. So the diagnosis of COPD. Hands up who are using spirometry in their practices. That is fantastic. So that was very much fewer hands shown a few years ago. I do think this is a very powerful tool. I think we underutilize it. I can tell you that the cardiologists have even seen this spirometric assessment in use, but it's too frightening for them to get their hands on it. But actually, it's a good predictor of cardiovascular death as well as respiratory disease. So actually COPD and spirometry, and in particular this reduced ratio of FEV1 over FVC is actually a predictor of all-cause mortality, particularly respiratory and also related to cardiovascular death. Now the key part of this, as I'm sure you know, is to ensure the patient has a very full forced ventilatory capacity by expiring out at least beyond 6 seconds or more. And that's really critical to get that bottom number correct. Otherwise, the ratio will be artificially elevated, and then the patient will not be diagnosed with COPD. So a full, long blow to the point that they're looking a bit blue is critical, as I'm sure you know. So on the background of that, we can make a diagnosis of the presence of airflow limitation. Hands up who does reversibility. Wow, that's impressive too. Okay, that's really good. If you have the time and the staff that are trained to do this, it adds information. And I'll show you where this comes in, excuse me, a little bit later in the presentation. So having reversibility testing is also a useful tool as well as the baseline spirometry. But don't be put off doing spirometry. If you can't have reversibility, getting the baseline spirometry is worthwhile. So we can grade people according to severity based on their FEV1. Excuse me. This has some relevance in terms of prognosis, not so much in terms of what we expect in terms of symptoms and disability, not so much now in terms of how we decide what we're going to give the patient by way of inhalers. Now this thing here, as I say, the ABCD or GOLD recommendations for dividing patients up has really been a challenge. When I first gave presentations like this, there were 3 variables that were supposed to go onto a two-dimensional figure, and that was bad enough. Even now, though, there is some complexity in placing patients, and GOLD, who represent these American, European specialists, are kind of tinkering with this story. But I think they're missing some important features, and I'll discuss that a little bit more later on. And this can be simplified, you'll be pleased to know. All right, so CAT score. You guys have got these in your handout. This is a piece here. Hands up who have used the CAT score. Okay, that's getting quite good too. So why would you bother? So it has been validated. It is an opportunity to score the severity of not just key symptoms such as cough, breathlessness, and sputum, but more systemic symptoms of fatigue, sleep, even confidence and energy, which I think are really important in the wider spectrum. We now see COPD as a multi-system disease. We see it as a disease where there is systemic inflammation, which actually makes people tired. And it actually reduces the capacity and functionality of skeletal muscle, the diaphragm, and so on. So COPD is not just a disease of the airways. It has much greater influence. The utility of this testing is an opportunity to see if the treatment changes you have made are working. Now, the patient may say to you, yes, I feel better, doc, but they may just be saying that to make you happy. And we all have patients that will do that. This is a little bit more objective. It's self-administered, it's free, and it does provide you with an opportunity to score symptoms on each visit. And this can help guide your decision-making around therapy. So this is, as I say, being well validated, and I would encourage you all to embrace it, give it a go, and have your patients fill it out. Now, I also have, I know from experience that one patient's score compared to another patient's score, they may look quite different to you clinically. It's really about the opportunity to follow that patient and how they report and score themselves over months and years of treatment. Okay, so it's a very useful within patient type of tool. Okay, move it on. So the more simplified way of assessing symptoms is just how breathless people are. And 2 is the cutoff. On level ground, I walk slower than people of the same age because of breathlessness, or have to stop for breathing when walking at my own, stop to breathe when walking at my own pace. And so that's the cut point at which we would feel people are beginning to show that they are compromised with their exercise tolerance. Now, let's get to the meat of the talk, if you like. The key aims of treatment remain the same, and that is symptom control and risk reduction. So symptom control is relatively self-evident. We're looking to reduce breathlessness, improve exercise tolerance, and the studies tell us that when we do that, it improves quality of life. So those are key features of the management in terms of improving the symptom side of the story. On the other side, we have this risk issue. Now, why is that important? So we're beginning to understand that exacerbations are indeed a marker of high levels of inflammation, that the more frequent exacerbations occur, the patient is on or at risk of a downward trend in terms of their lung function, and also that more frequent exacerbators have higher mortality. And I'm going to show you some data today, which is the first of its kind. It is as yet unpublished. I've seen it in abstract form in the American meeting last May, and it looks at mortality, and it raises some very interesting issues around exacerbations and their contribution to mortality. And that'll come up a little later. Now, this issue of slowing disease progression, what does that mean? That really means maintaining exercise tolerance at peak for that person as long as you can. It's also about reducing the steady decline in lung function that we see in some patients. And it's probably in the wider setting, I would argue, about reducing overall systemic inflammation. And just so I don't forget, exercise is now recognized as a key feature of that. So even in your patients with COPD, regular exercise is useful and it has anti-inflammatory benefits. Now, reducing mortality has been the holy grail for the respiratory community in offering treatments. And I would say that we're starting to touch on this now. The data again today will show you some inhaler-based treatments and some mortality outcomes. But for example, in the US, and this is work that I've been involved in lung cancer screening reduces lung cancer mortality. And this is very important in patients with COPD. and a focus on cardiovascular disease, because patients with COPD have subclinical cardiovascular disease. So there are opportunities where we know from a prevention perspective, we are able to reduce mortality. So I just leave you with that thought. Now, what are we doing with inhalers particularly? So LAMA, the tiotropium, meculodynium, glycopyrronium, these are long-acting muscarinic antagonists are useful in reducing exacerbations and symptoms. Now, in this schema, I've put in LAMA monotherapy because in New Zealand, we required a use of LAMA monotherapy as part of a special authority for LAMA-LABA combination. Okay? And in fact, I'll show you a little bit of data to suggest LABA monotherapy is certainly less effective than LAMA monotherapy. So if you're starting a patient on maintenance therapy for improving their airways, then LAMA would be preference over LABA. Okay, and there's lots of clinical data out there, and this is uniformly agreed, or as best as you can expect for the respiratory community, uniformly agreed as being superior than LABA monotherapy. Now, on the exacerbation side of things, we've now got a choice, and it's this choice I hope to help you with in today's presentation. Do you use the new LAMA-LABAs, long-acting muscarinic antagonists, long-acting beta agonists, or do you use the traditional ICS-LABA? And so hopefully there'll be some data to help you with that. And then, of course, there is the opportunity through dual inhalers to have people on triple therapy. And as I say, in the future, there'll be single inhalers that deliver all three medications. Now, this is something we published a couple of years ago in the European Respiratory Journal, and it was an attempt to try and factor in ACOS, or ACO. What is ACO? ACO is the asthma-COPD overlap. And what this really represented was a whole interest, a new interest in this group of patients that had asthma earlier in life. They may have grown out of it, or they may have continued to have minor symptoms or significant symptoms, and on a background of smoking, went on from reversible airways disease to irreversible airways disease, and then really, for all intents and purposes, quite restricted exercise tolerance as they developed more and more severe irreversible airways disease and COPD. And it uses the traditional A, B, C, D, and we put an E just to reflect this group. Now, why is that important? These group of patients have been excluded from asthma studies and COPD studies. So in the real world setting, we do not have data on this group of patients. So this is a recommendation based on opinion, common sense, whatever you like, but the feeling is, and again, this is universally recommended, is that patients with a strong asthma background, as one feature, who've now transitioned to COPD on the background of some smoking and irreversible airways disease, should be treated as ACO, and on that, their transition to triple therapy, if that's where they end up, goes through LABA-ICS preferentially. These people are ICS, or inhaled corticosteroid responsive. Okay, and I'll talk more about that in a minute. Now, this is what I'm proposing as a slightly simplified approach to COPD. This is the money slide, if you like. So what have I done here? I've taken this concept from NICE, which is some nice people in Europe who've made recommendations in Europe about the treatment of COPD. And what they've done is they've recognized this group of asthma-related COPD, and down this arm, after you've gone from short-acting reliever therapy, you would be using a LABA-ICS, and you would be considering triple therapy if this individual continued to have high symptom scores and suffered exacerbations. On the other side, in someone whose COPD has not got an asthma origin, if you like, or is not asthma related, you have a decision of a LAMA, and you can either consider from there with persisting symptoms a LABA-LAMA, or if you're a believer in the eosinophil story, you might choose LABA-ICS preferentially. Again, recognizing that this group and this group are ICS responsive. Now, there continues to be a little bit of debate about this. The respiratory world is always debating stuff, and this happens to be one of the current debates. But certainly, There is now, I think, a body of evidence, and some of I'll show you briefly in this presentation, to support this idea that people who have persisting elevations in their serum eosinophil count on a full blood count may be more ICS responsive. Now, why is that relevant? It's really relevant if you were to just decide to withdraw a patient who are already on an inhaled corticosteroid and put them onto a LAMA-LABA alternative and take away the ICS. And the idea is that you would not do that in this group, and you probably would not do it in this group either. So if you were looking to de-escalate therapy, then this is the group over here where they have persisting low eosinophil count that you might feel comfortable in doing that. And I'll show you some data that suggests this may be very important. Now, what are the benefits of dual bronchodilation? Just to say that you've got this lovely combination of the LABA-LAMA, dual acting. It makes perfectly good sense that this is a good way to go because you've got two different pathways you're now activating that are providing an opportunity to bronchodilate and maximally bronchodilate this group of patients. And so it makes sense to incorporate them in your treatment choices. Oh dear, that wasn't good. Okay, so what do we know? Well, we know that patients that are on long-acting mono maintenance therapy, the symptom scores are still quite high, even in mild to moderate COPD and those with severe disease. So a score of 2, that was that MRC score where I'm breathless, walking at my own pace, have to stop for breath. There's quite a sizable chunk here, 50% here, 60%, that are still scoring high on these breathlessness scores. And so in that regard, you can see that's the sort of patient that would benefit from going from monobronchodilator to a dual bronchodilator, where breathlessness is their primary issue. There are studies that show what we would have intuitively expected, and that is that dual therapy is superior to monotherapy. And that's simply what this shows. And, you know, are these increases clinically relevant is always the debated question. Around 100 mils is thought to be clinically relevant. So I think dual therapy superior to monotherapy. Okay, what about comparing the utility of each of these? Well, if you compare different types, in this case of LABA monotherapy, the increases in FEV1 are relatively modest. And really, I think the key to this is in deciding which therapy you use comes down to patient acceptance of the inhaler device, what you're comfortable with, what your patient is comfortable with in handling the inhaler and getting good disposition or deposition of the material into their lungs. And so I think rather than a sort of head-to-head, one is better than the other, in this regard, the study showed that both of these drugs are useful at reducing exacerbations. These drugs also improve bronchodilation, but choice may be more regarded to patient acceptance of the delivery device. Again, here you can see a little bit of superiority here, and this is for the LABA-LAMA combination. 50 mils in the FEV1, you know, is that clinically relevant? Some would argue not really. Now, which of my patients would benefit from an inhaled corticosteroid, and how should I manage my COPD patients with a previous diagnosis of asthma? Well, I've really already told you at least half of the story, but I'll keep repeating it just to hope that it sits nicely and comfortably with you. So for patients with persistent exacerbations, long-acting monotherapy escalation to ICS-LABA or LABA-LAMA makes good sense. The ICS-LABAs are preferred for patients with a history suggestive of asthma, and patients who are thought to be responsive to inhaled corticosteroids are also a group of patients that you might preferentially go to LABA-ICS. This is a brief intro into what is asthma COPD. It's the definition that is generally accepted in the respiratory community. History of asthma is key, and this is asthma in childhood or in the first 2 to 3 decades of life. There's a feature of smoking in there. They often have features of atopy with allergic rhinitis, eczema. They may have elevated serum IgE, and there may be features of high serum eosinophilia. And just think of 300 as the cut point for now, while the respiratory community further debate the issue of what level exactly. 300 is generally accepted. So when it's elevated, it would be a feature consistent with an asthma type of COPD. Variability in FEV1, and this comes back to my question or my comments about measuring reversibility on spirometry. If your patient has a high degree of reversibility after a short-acting beta agonist, Ventolin, for example, and they show a significant increase, say greater than 400 mils in their FEV1, then this would be indicative of having a highly variable airways disease and a more asthmatic component to their COPD. So, as I said, greater gains in using ICS in reducing exacerbations and with greater responsiveness. Now, this then I think helps dichotomize your COPD populations pretty much into the asthma group and the non-asthma group. In the non-asthma group, escalation from LAMA mono to LAMA-LABA dual, and then triple if that's required, if they're still having symptoms or exacerbations. Here we reverse the order a bit and would place LABA-ICS in place of LAMA-LABA. Now this continues to be an area undergoing clinical trial and review. So what GOLD or this august body do is they review the clinical trial data that is provided, and every year or two they come up with slight variations on this theme. So be prepared for change. But for now, I think this is a good place to be. Now, we know that inhaled corticosteroids do a good job at reducing exacerbations. ICS-LABA better than placebo, consistently 25% reductions in exacerbations, left of 1. Interestingly, the ICS-LABA compared to LABA monotherapy, it's pretty much the same. And it's on the basis of data like this that people have felt that LAMA is better than LABA alone, particularly in reducing exacerbations. When it comes to ICS-LABA and LAMA-LABA, the data is mixed, and we now get a sense that it depends a bit on the COPD phenotype, that is to say, the asthma component. Right, let's get to the money then, the ICS. What about withdrawing it? So there are obviously concerns about pneumonia or other ICS-related complications from chronic low-dose inhaled ICS use. And the group of people that we worry about particularly, apart from those who've had pneumonia, the current smokers, those of an older age group, gee, I'm in there already, poor lung function, low body mass, and high comorbidity. And this is a group of patients that might find or might experience more pneumonia with ICS use. That said, inhaled corticosteroids are very good at reducing exacerbations, improving lung function and quality of life. So let's focus then on de-escalation or withdrawing ICS. Okay, the inhaled corticosteroids. And what I've indicated in this algorithm is that this would not be recommended in those with an asthma base to their COPD. It wouldn't be recommended in people who have a more eosinophil-related type of COPD with chronic elevations, persisting elevations of their eosinophil count on their full blood count. But this group here, who we think stand alone compared to these two, you might consider ICS withdrawal. So that looks a bit like this and is shown in the green box on the right. And what you see here then, ICS step down or de-escalation, not if they're ACO and not eosinophilic COPD. So I've showed you that in the previous. I wouldn't do it if they've had a recent exacerbation. So that if really to do it, you really want people to have not exacerbated or had a chest infection in the last 1 to 2 years, stable breathing. You'd consider de-escalation if there had been a recent pneumonia, particularly chest X-ray confirmed, or other ICS-related complications, and they had a low blood eosinophil count. This gives us confidence that withdrawing ICS won't result in a sort of breakthrough exacerbation. And this has been the experience of some clinicians I've talked to who have withdrawn ICS, so the patient comes back within a few weeks or months with an exacerbation. It's always a risk. We always take these risks sometimes in the course of treatment. I think this approach will help reduce that scenario. Okay? Now, triple therapy. What's going to happen here? Well, triple therapy is an attractive approach to treating COPD because we are looking at 3 separate pharmacological pathways. one that's anti-inflammatory and two that are bronchodilating. It remains a bit of debate about the anti-inflammatory effects of some of these two agents, but I think that's still at research level. But we do know that both bronchodilate and together they give maximal bronchodilation. So triple therapy, I think, is an inevitability, and some patients will already be on triple therapy. Show of hands who can remember patients that are on triple therapy. Certainly the ones I see in the hospital are on triple therapy, and I think that's appropriate because they've had a significant exacerbation. Right. So the IMPACT trial is a GSK-funded trial that looked at all three groups head-to-head and asked the question, over 12 months of therapy, which of the three treatments did best? Okay, which of the three groups that were either randomized to triple therapy, randomized to the LAMA-LABA, or to the ICS-LABA. Now, just to point out, this group here, the inhaler was a single inhaler. And we do know, and some of the, I think the benefits of these treatments is that you've got once-a-day therapy, the compliance is easier, there's issues around the device and delivery. In this particular trial, that was taken out of the issue by using the Ellipta inhaler device. And you have one of those on your seats as part of GSK. This is a device that is a click and suck device, and as long as people click properly and fully and take a deep breath, then they'll get good delivery. So in a way, it was a good chance to take out delivery device and look at the pharmacological effects across these three groups. Now, it studied a broad and generalized population of COPD, history of exacerbation, moderate or severe in the last year, and who were already on some form of long-acting maintenance therapy. Now, where it gets interesting is, what you're doing is you're taking a group of patients and taking them off their existing treatment and putting them onto one of these three choices: triple, dual with steroid, dual without steroid. So as I say, the study ran for 12 months. What was interesting about the three groups is they were on randomization. They were very similar in terms of important features. Their FEV1 was in that moderate to severe range, around 45% of predicted. Interestingly, about 70% of them had suffered at least 2 moderate or 1 severe exacerbation in the preceding year. And around about 66 to 70% of them were already on one form of ICS. Now, I find this interesting in that one of the concerns that the respiratory community and probably Pharmac have is if triple therapy was available, then everybody would be on it. And I'm not sure if that's the case. And in this particular group of severe COPD, only about 40% were actually on triple therapy with dual inhalers. However, this becomes important when I show you the results a little bit later. This is the exacerbations after 12 months of follow-up, with the LABA-LAMA on the right here having the highest exacerbation rate, and the triple therapy on the left having a significantly lower exacerbation rate. So this is moderate severe exacerbations, 25% reduction. The same comparison here and here shows a 34% reduction for hospitalization. So these are impressive figures and indicate, to me at least, that ICS is contributing possibly something quite important here. There is a lesser difference in the ICS-LABA, but nonetheless, this group is still superior to the ICS-LABA, indicating LAMA may have a small contribution as well, as we might expect from prior data on LAMAs in reducing exacerbations. So just to summarize then, a greater reduction of around 25 to 30% in exacerbations over the year of treatment. Now, this is some of the data on blood eosinophil counts. You've got the former smokers here and the current smokers here, and this is an endorsement of why COPD patients need to quit smoking, because their ICS will be more effective. Take a look on just the two right-hand bars here. This is high eosinophil count, 200 or more, 23% reduction in exacerbations, 28% reduction in exacerbations, triple versus LAMA-LABA, ICS, no ICS, no effect at lower eosinophil count in current smokers. If those people quit, we suddenly see a response, even at lower levels of eosinophil count. But the response is greater when they quit smoking. So greater ICS responsiveness when people quit smoking. Make that a goal in encouraging your COPD patients to quit. If you want to get better, if you want these drugs to work, you need to quit. So just another tool to point that out. This also shows this interesting relationship between inhaled corticosteroids and smoking status, and also it highlights this interesting cut point of around 200 to 300 on the blood count. Now, this is data that's not yet published. It's incredibly exciting, but it carries with it some controversy. This is mortality data shown here over the 12-month period, with the LAMA-LABA having a much higher mortality, and the groups who were randomized to ICS dual or ICS triple having a 40% or thereabout 40% reduction in all-cause mortality. And this is highly significant. This is the most significant result that's ever been reported in reducing mortality in a COPD trial. Now, the devil is in the detail. And so I'm going to introduce a concept to you that I think is worthy of thought, and it's going to be the basis, I think, of more discussion. This interesting result was not published in the original New England Journal article because there was an issue of follow-up. There were patients that were lost to follow-up, and the editor of the New England Journal was not happy and really asked GSK to go away and follow up this other group of patients that were otherwise lost. In other words, they needed to find out whether they died or not, what happened to them, and was this result for mortality skewed by that group of patients. And indeed, that analysis has now been done, and the data shown here is now being submitted for publication. So why is it interesting? This difference shown here actually started here, and the differences in those three treatment arms diverge or separate very early on in the first 4 months of treatment. This group did badly. And after about 4 months, the run's a little bit parallel, okay? Now, as I say, 40% reduction in mortality, even the cardiologists would be impressed with that. So it's an impressive result, but it does require a bit more thought, and it also requires some more analysis. This data has been reappraised by a guy called Sami Suisa, who's a guy who really looks at clinical trials in the respiratory world and tears them to pieces and asks why did that happen question, which I think is good work. He published an article that suggested that it was in the first 4 months where there was a significant difference in mortality, and showing it here on a month-by-month basis, and I've just shown you in the larger graph that first 4 months being relevant. Well, Sami Suisa believes this is to do with these first 4 months of treatment, and has gone on to suggest that maybe this is an effect from withdrawing ICS from this group of patients and putting them on a LABA-LABA. And remember, 70% of those people were on an ICS, and now that's been withdrawn and they're on a LABA-LABA. Have they actually had a withdrawal breakthrough with exacerbations? Now, why would that happen in this study? This study included people with asthma, but we don't know exactly how many, and more particularly, we don't know what that really means. What was their asthma? Was it asthma in childhood, asthma in early adulthood, and so on? Was there IgE-related disease? So that asthma phenotype was not carefully collected, the data for it not carefully collected in the study. What I thought was even more intriguing is if you look at the excessive exacerbations in the LAMA-LABA group, that also happens to be in the first few months. And so I think it's behest on GSK to explore this event and this event, exacerbations, excess exacerbations, and its relationship to mortality. Because we do know that when patients exacerbate, they have a high inflammatory load. It's often virally mediated, drives your cytokines crazy, and with that CRP is elevated, systemic inflammation is high, and cardiovascular disease is an important complication around an exacerbation. And that risk goes out to 2, 3, 4 weeks post-exacerbation. So a cardiac event can follow. And in fact, some of the work done at Waikato Hospital showed this with elevated troponins and BNP in patients who came in with a COPD exacerbation having concomitant cardiac disease, presumably subclinical ischemic heart disease. Okay, so I think there's some interesting issues around this, and this may be a very important trial in enlightening us on who not to take ICS off. But I think it's also impressive in terms of the utility of inhaled corticosteroids over LAMA-LABA. So we just need to bear that in mind, just to remind you that the group that were in the LABA-LAMA, 70% were on ICS, and after randomization, they had their ICS removed. This is the biggest kind of pharmacological change across the three groups. So I think there's more work to be done on this data. Now, device and what's relevant there. We know that patient error is an important, or misuse of inhaler, is an important part of hospitalization, emergency room visits, oral corticosteroid use, and antibiotic use. And it increases roughly 50% risk across various studies. There is, as you will know, patient dexterity, understanding, coordination, and so on. And with that, their ability to be able to coordinate metered-dose inhalers versus dry powder versus click and suck, and so on. This is a study that looked at some of those issues. It found that the patient error rate, or critical errors, were less with the Ellipta than some of the other inhalers. But I think it really comes down to your judgment and the patient preference. Now, non-pharmacological, I don't want to skip over this or in any way underemphasize this. Smoking cessation is number one. And I've shown you some data now why it's not just about all the other risks that go with smoking, not just about the inflammation that goes with smoking, the promotion of airways remodeling and ultimately lung cancer, but it's also relevant in terms of response to inhaled corticosteroid. And hopefully I've shown you that inhaled corticosteroid still has a role to play in the management of COPD. So please continue. I know it's an incredibly hard job to encourage people to quit. Pulmonary rehab and exercise, particularly exercise after pulmonary rehab and between exacerbations, is becoming more and more important. And the realization that we should be encouraging patients to have 10 or 15 minutes per day of exercise, preferably that makes them puff a little bit, even though they may be quite disabled with their breathing. So exercise in terms of its wider utility, terribly important. Pulmonary rehab in itself is obviously a different intervention according to where you are and what's available from your local physio, specialist nurse and respiratory community, but really has a very good social component to it, the group setting, as well as the inhaler technique, as well as the exercises and so on. It's quite a multifactorial or multi-dimensional intervention, and done well will give patients significant benefits 6 to 12 months, out to 6 to 12 months. Part of the key to that is maintaining patients on an exercise program at home. Okay? Vaccinations continue to be important. An influenza yearly vaccination, influenza, pneumococcal every 5 years in those at a high risk, more severe disease, previous pneumonia, and so on. Diet is growing in interest across the spectrum of disease. When I say that, I mean diet's always been part of cardiovascular medicine, lowering lipids and all of that, because of this whole issue of systemic inflammation and recognition that COPD patients have high rates of coronary disease, and they have the sort of coronary disease that diabetics get. It's distal, it's multi-segment, it doesn't present with angina because these people don't exercise enough to get angina, and it's very poorly treated in terms of revascularization, and it's omitted. So a little bit of side data, one of my pets, and I'll come back to it down here, but think about diet as part of overall cardiovascular risk management. And so the Mediterranean diet, or what I call the 4 Fs for vegetables, fish, fiber, and fruit, for good anti-inflammatory Mediterranean, live long in life and well, more importantly. Inhaler technique really should be right up here, and I apologise for that. It is always recommended to be reviewed with patients. It is an important feature of the utility of these inhalers that the patient really uses them correctly. Comorbid diseases, so in the wider community of COPD, the two leading causes of death actually are coronary disease and lung cancer. So what do we know about coronary disease and lung cancer? I've alluded to the issues around coronary disease. These people have heart attacks without chest pain, if you like. They have a lot of coronary disease that goes undiagnosed, and I personally believe that this is a significant feature of death in COPD patients, and to my mind, worthy of primary prevention. But look, follow the recommendations by all means, and look at patients and look at their independent cardiovascular risk. But remember, a reduced FEV1 is just as important or equal in importance to an elevated cholesterol for a cardiovascular death and event. Okay, FEV1 is an independent predictor of coronary death. So it can be factored in here as part of your assessment, and you can decide whether they should be on aspirin and statins. Lung cancer is an interesting issue. Lung cancer is often delayed in diagnosis in patients with COPD because they have already had cough and sputum, and because these symptoms have pre-existed the development of their lung cancer. So be alert to patients who have persisting breathlessness and persisting cough or chest pain despite treatment. Okay, so chest pain, not normally a feature of COPD, and cough would normally respond to antibiotics and or prednisone with inhalers. So this group, oopsie, I apologise. This group down here who are presenting have persisting symptoms, think about imaging. And you guys can get chest x-rays, and if you're still worried, refer them for CT. Hemoptysis, obviously a red flag, we all know that. Weight loss and night sweats, also red flags in this group of patients. Patients with COPD have 2 up to 4 times higher risk of developing lung cancer than smokers of equivalent pack years with normal lung function. And as I say, we have identified molecular genetic markers that show that the genes of susceptibility are indeed overlapping. Right, just to wriggle on to get to the end. So this is really a summary then. Just to try and simplify it, asthma-related COPD, LABA/ICS triple therapy. Non-asthma related COPD, traditional LAMA, LABA, and then triple therapy. And the eosinophil group is inhaled corticosteroid responsive, as is the ACO group. So just bear that in mind. And I think you'll see more and more recommendations coming out along these lines. This is, I would say, also pretty consistent with BPAC, who've done a great job in their recommendations for COPD management. So I congratulate BPAC on doing that. So I'll stop there. I thank you very much for coming this morning.